Welcome to this second panel for the day, and in some ways, listening to the prior panel and then going into a panel called Rethinking the Social Determinants of Health. In some ways, I'm not sure what one can add. We really heard about the unbelievable importance of drivers of health that go way beyond clinical conditions and sort of technical medical needs. We also got a flavor of how we can get interventions so wrong when the answer to a very traumatic incident is the further militarization of a community. That's an example of going really wrong when you're not, when you haven't really understood what was going on to begin with. But what we will do is, to some extent, take it to another sort of an intersecting space and talk more broadly about what impacts health, how it intersects with the healthcare system. But I luckily, the four of us were at the little gathering last night, and so we've had a chance to meet over food and drink. So as a result, we're going to get hopefully a little freer here with the conversation, including pushing each other and having an engaged conversation with you all. And they don't know what they gave me permission for, but they gave me permission for something.
We might need more food and drink.
No, I don't think we need permission for more food and drink. But so just to first kick it off, this is a panel. I'm joined by, I'm going to use first names, by Chiquita, Eliza, Matt, and my name is Minnie. And one of the reasons why I like first names in this kind of context, in other contexts it's actually important to use titles for in certain specific scenarios, but here, because one of the non-medical drivers of health is the power that comes with the title doctor. Which I retaliate against. I'm a vice dean at a med school. My best friends are docs. I'm actually a behavioral and systems neuroscientist by background. But I find that problematic in so many situations. I find myself like taking a step back and going, having that unconscious conversation around, am I worthy to add a comment? And it's taken me decades to sort of deal with that. And I cannot imagine what other people feel when they go to talk about stuff they know the most about, their health, but are faced with the power of a title and don't feel, therefore, that they have the right to ask or to question. But before we go off into talking about with Chiquita, Eliza, and Matt and myself on sort of the rethinking social determinants of health, this terminology, social determinants of health, I am sure there are people here that have a range of pet peeves with those words. I'm sure my colleagues here have pet peeves with those words, some of which we explored when we were doing our prep. But before we did that, I just thought maybe it would be fun to just hear anyone who loves the phrase social determinants of health, hates it, prefers another word, has another related pet peeve. Let's just start airing that right now. Because in fact, terminology in this space is evolving. And as we dig deeper, words will matter as much as we should also be comfortable with just being loose when it helps us. So, pet peeve, social determinants of health.
I'll get us.
What was that?
I'm just saying I hate it. Only because I have heard from legislators, right, that they say this is socialism, right?
It's a?
Socialism.
Socialism.
Okay. And then besides that is determinants. Okay. Does that really determine who you are, right? There's a driver, in my opinion, right? And I feel that a better, in my opinion, again, terminology is non-medical drivers. And I was having this conversation, I think Bruce, right? Yeah, we were having this conversation yesterday, and I have had this conversation with other people. It's like, words matter, like you guys were saying, right? And people hook on to socialism, social drivers, determinants, whatever, and just there are things outside of us, like that create us to be healthy, right? And what are those upstream items that we need to look at? So anyway, that's
Thank you. Yes, another pet peeve.
I have a thought about it, and I just saw that line is very important when deconstruct. My name is Jesus Ortega, and I work with the Office of Diversity, Equity, and Inclusion at the Medical School. It's the fact that when we say non-medical determinants of health, we center in medicine, as it is the source, right, of not all the other problems. And centering medicine could be tricky when we're talking about what is the impact that communities are having for not having the infrastructure, as we saw in the first panel, to be able to address the infrastructure issues that we have, the systemic issues that we have. Because it's not just medicine. I mean, we do know that medicine is 20% of the social determinants of health. So how do we, and then we center in that field. And this is a multidisciplinary effort if we want to create such changes. It cannot be just medical.
One of our predictions was that everybody in this room could join the panel with us.
Well, thank you. No, thanks, Jesus. And I don't, sorry, what was your name, ma'am?
Oh, my Iris.
Iris and Jesus. That was a great back and forth. Now, I'm going to, for a moment, we're going to get back. So if you've got your pet peeve, hold on to it. We'll have space for it, because that's super fun, is to get one's pet peeves out in a friendly group. But I'd like to take the moment then to now go to my colleague Chiquita for a second. Among other parts of Chiquita's expertise and career is that Chiquita has really, firstly, worked in this area for a very long time. Worked in various parts of a couple of different institutions. I think about the AAMC, which is one kind of sort of institution, and then also within medical centers, as well as the fact that you bring other research and scientific expertise on a different level as well. So perhaps you could introduce yourself, but then use this moment to then respond perhaps to Iris and Jesus's comments.
I know Jesus. So I am Chiquita Collins. I'm the inaugural Chief Diversity Officer and Vice President at UT Health San Antonio. I do serve with the Association of American Medical Colleges as the chair for the group on diversity and inclusion. And as many mentioned, I've been in this for over 25 years as it pertains to producing scholarship in the area of social determinants of health. And so, yes, I do like the term. I do know that nomenclature will change and evolve, and there are perceptions by which people may see it in an unfavorable light. I think you have to define it in order for people to understand it. And so, given that I'm in academic medicine, in the last 10 years, we have embraced social determinants of health as it pertains to training our next generation of physicians and basic scientists, because prior to that, public health has been the field by which it had it started, it launched. Social scientists, complementary to public health in terms of providing the framework. But as a practitioner, now we get to really be from the point of view of medical students in particular. They have an oath, a Hippocratic oath, by saying, do no harm. However, there's been studies such as the Institute of Medicine that came out in 2022, I believe. No, before that, what am I thinking? 2007, right? 2002. And it had over 500 studies to document that even controlling for all the multiple factors that one can think of that may contribute to health disparities, there's still inequities that exist amongst marginalized populations, indigenous BIPOC populations. And so the key factor that we argue in terms of my work with David Williams, who's at Harvard, is that the fundamental root cause of the existence of disparities, primarily in urban areas and rural communities, is the extent to which discrimination is prevalent. And I'm talking about systemic barriers. I'm going to call it what it is: structural racism. We see it, and I think the power that bees is that we have to really change our procedures, our policies, and our practices. Because we can put our energies in terms of intervention, and only 50 or 40% of one's health trajectory is driven by behavior. 30% genetics, 20% environment, 10% healthcare access and quality. And we spend a lot of time in terms of healthcare and changing one's behavior. And you have to be conscientious because we say that you're not engaging in proactive health behaviors, and so you're making bad decisions. People who are poor, people who are marginalized, people who are minoritized, you're doing something wrong. So let me create an intervention program so that you can get it right. Well, let me tell you, I come from the side of being poor, and we make choices. Health is not a high priority. I'm trying to feed my family on the scarce income that I have. We have to talk about changing the quality of education. When we talk about urban and rural communities, education is based on property tax. If I'm more inclined not to own my home, I am a renter, I don't contribute to that bucket. And so politicians make a decision. Advocacy groups make a decision that weigh in terms of the quality of my life. So we have to empower people in ways in which I'm not knocking in terms of, what we do because it benefits, but we have to take a more holistic approach in understanding the individual in those communities that continually are disenfranchised. I'll pass the mic.
Well, thank you for that amazingly important setup. And we're going to take that as a base. I'm not sure that I'm not going to say it because I've already started with pet peeves. Maybe there are people here that would disagree with elements of it. I might quibble about some small pieces of it. But as a whole, I think we're in this room really, and you've really inspired us to now say, okay, so what next? But before we go there, I also want now Aliza, who looks at individual patients. She teaches. She really helps individual patients, and among them, some particularly, especially in today's environment, particularly vulnerable groups, LGBTQ, transgender patients. And so do you want to reflect a little bit on sort of the dynamic between the medical and the larger sociopolitical, structural determinants of health, but but also this notion of how the work with the individual might connect with work at different levels. I'll just state up front that I'd like us to think about strategies and movement building. And in strategies and movement building, it is never one or the other. It is multiple pieces coming at multiple levels, and you just want to make sure that you don't step over each other's toes so much that you block any movement. So do you want to reflect perhaps on those tensions, Aliza?
Sure, and I, resonate with everything that Chiquita said, and the first panel, it was just so relevant to my practice as a primary care physician, which you maybe wouldn't think that immediately, but I'll say a little bit of background about how I got into primary care. I trained in a primary care track within an internal medicine program. It was an academic program at UCSF, and when I graduated, I felt, even though I was in a primary care track, much more competent taking care of patients in the ICU than I did in the clinic, because we just get trained in this very kind of medical intensive way. And what drove me to primary care was seeing patients in the hospital, because I did work, as an attending afterwards in a hospital setting, and especially in internal medicine where you have, internal organ dysfunction, so many people dying of preventable things. And it was very depressing. And the lack of good primary care and good preventive medicine was just so clear. So getting into primary care, what I recognized over time was just how important so many of the things that we're talking about are. That it is so important to have an interdisciplinary care team that is talking about the ways in which these social determinants or non-medical drivers are contributing to health, because before you get to an end-stage state of disease, it is nuanced. You don't have labs telling you, oh, this person's liver is not working anymore. That's pretty clear. I have a clear path to go down in terms of treatment or what to do next. It is nuanced. You have to really understand, what else is contributing to this patient's symptoms right now, because it's not super clear cut. And to do that, you have to know Where are they coming from? What's going on at home? Are they telling me the full story? Can I ask this question to get a history in a different way? And that requires time, which primary care doctors don't have. 15 minutes, you cannot establish trust and you cannot get a really good nuanced history in 15 minutes. And it requires identifying needs that are outside of those medical needs and then finding appropriate resources. So I know we don't have a lot of time, so I'm going to say, my experience as an individual healthcare provider and what I'm trying to distill into like teaching pearls for students so that they also start to understand this from, the beginning of their careers. There are 5 major needs that I see as it relates to our work. And I'm happy to talk in detail about any of these, but I'll state these and then see what people think. So tailored care plans. So understanding, what do you need in your care plan, and how does your environment influence what I'm going to prescribe for you? For example, somebody experiencing homelessness who doesn't have a fridge, I need to take that into account before I prescribe insulin, right? Or if they say I'm not taking my insulin, I need to ask why. And I can't tell you how many times I've been precepting in resident clinic and they say, patient's not taking their meds, they're not adherent, so I'm going to switch them to this. Why aren't they taking their meds? We are rushed and we don't have enough time or enough empathy to ask those really important questions. People have brought up incorporating community into these decisions. Same thing goes for our individual patient-provider communications, incorporating the patient into their care plan. So I always tell my patients, I am your consultant. I have experience and I have knowledge in medicine, and so I'm going to give you recommendations, but you have the ultimate say over whether you take that recommendation or not. And you can ask me questions about why I'm recommending it. And if you decide something different, I will support you. So, really centering their control in the care plan. That requires trust. So we need to have physical spaces that promote trust. So that means for, patients who are coming from backgrounds where there is a lot of discrimination. So I, see transgender patients for gender affirming care, having visible signs, having flags, having, pronouns on my name tag, having this is a safe space for you to enter, and I'm going to give you the time that you need. That's really critical. And then resources. We can't ask patients what they need in terms of their social determinants of health if we have nothing to offer afterwards. And so I work in now an HIV primary care clinic, and I have a housing department, I have a food pantry, I have behavioral health, we have case managers. I am extremely lucky, and part of the reason that I am in this line of work is because I can do what I feel like needs to be done for patients because of all of those resources. It is not fair that somebody living with diabetes and not HIV does not get those resources. And that the reason we have so many resources is because all of the amazing advocacy that so many people living with HIV did in the 90s and and throughout. And that's great, but it's not fair that we have buckets of people who get resources and don't get resources. Here in Austin, we have a safety net system, the medication assistance program, only if you live in certain counties within the Austin area. Now Austin's so expensive that I'm seeing more and more patients who are coming from outside. They can't afford to live in the place that has the safety net. So those resources without requirements is another thing that we absolutely need. And then the last one is advocacy. I'm going to stop talking.
That's great. No, thank you, Eliza. And we'll have a chance to, I have got this, but we'll have a chance to ask questions of our panelists. I want to move to now, and first I want to encourage you to keep putting ideas on Think, Do, and Fund. I love those 3. So and don't hesitate to do that while we're talking as well. That's fine. But I want to move to strategy, just to give you a sprinkling of the kinds of things we could then get into Q&A about. And for strategy, I'm going to share a little bit about the tack we take in our work, and then I'm going to turn to Matt, who's going to really talk about a big sort of data approach, which is a big part of our strategy in addressing this work. So on strategy, which cuts sort of across all of the above, first I'll say one of the, especially looking at Think, Do, and Fund, one of the things that I was struck with is just the huge discrepancy in the sources of funding in the kinds of sectors that would care about health and well-being. And the big dog in the crowd is someone who's got the most money, systemically. Healthcare, who said that? Wasn't you, Lisa? Who said that? Yes, healthcare. 20% of the GDP, 4.3, probably more trillion dollars. Public health, less than 0.5%. So follow the money. That's my attempt at strategy. And the big money is in healthcare. Not just big money is in healthcare, it is excessive. We pay double per person than the other developed countries. We also get worse results, we'll get to that. But we know we pay double per person. So $2 trillion, I'm just doing simple A to B to C, $2 trillion is just rubbish that we're wasting. $2 trillion, 10% of our GDP. So the opportunity, why not have big ambition? The opportunity is to turn that $2 trillion to things that matter, that we've talked about. Big, it's how do you get it out of the healthcare system? It's not an easy thing, of course. But at least the end result of this complicated approach would be a big win, not a small win. So when you get it, so for one strategy, and there are many, by the way, this is an example, you all will share others. So when you start looking there, then you start asking, how do you turn the funding that is trapped in healthcare, the excessive funding, towards things that matter more? And that is what several groups, organizations, many people have been working on for a long time. But it requires an engagement with the healthcare system that gets into the innards of the healthcare system and how it works. And so that's one element of why everyone can come in. So, but while doing that, we have to also align it with the bigger discrepancies that you were talking about, for example, Chiquita, and that you referenced, Elisa, at the base. And so let's take food. So food for health is a very big thing now. Everyone's talking about how we might be able to pay for food by healthcare systems. Things are moving just a little bit. This is how things move in healthcare. So first, no interest in food. Now maybe interest in food. So meals happens to be something that people are starting to pay for those that might require meals at home. The good news is that there is an industry, well, the somewhat news is that there's an industry waiting to deliver this non-medical support because they've been around for a long time. They've been doing other kinds of business. So they're national meal providers, right? The infrastructure of like dropping off meals outside someone's door exists. So as soon as they sniff, oh, $2 trillion, $4 trillion, healthcare industry, brand new customer, maybe paying, well, let's turn our business to getting that money. So when they do that, they come right in, and immediately healthcare works the way healthcare works, which is it looks at this sort of commodity and service model and says, all right, so you want a meal, how much are you going to charge me per meal? $5. So then we have other kinds of groups that do this that have for a long time been building up from the ground. So Meals on Wheels is one example, right? Where they really understand the needs of low-income communities that are food insecure, that are homebound, and have been doing this for a long time, have that expertise. And they do a daily model, they meet people, they provide the meal. But when they go, because they're also like, we need a sustainability model, they go to the healthcare insurance company, who has a lot of money, the insurance company has begun saying, that's great, but you're charging me $6 per meal per person. This group here is charging me $5 per meal per person. Sorry. If the large provider that's charging less provided a service that improved health, that would be one thing. But firstly, we have no idea. Secondly, most people in the room can guess that there are benefits to being seen several days a week. There are benefits to getting at least one of those meals as a hot meal, as opposed to we've done customer checks, right? I've ordered those different companies. I've ordered the drop shipment, the big box that comes once a week with a frozen meal. I can't tell you how not great it is, right? And so all of that has not been asked, but healthcare has immediately gone to, okay, what's the cost per unit price? We got to change that. But worse than that, what's happening now is who works in the food industry? Lots of well-off people with lots of health insurance, good standard, no structural racism whatsoever. No. So the price pressure that is happening on the unit price that healthcare is putting on is actually oppressing the people that are the most vulnerable who already have least access to healthcare. So I'm not saying that one group can address all of the above, like getting healthcare to pay, making sure structural racism is out of the food industry, et cetera, et cetera. But there are models in other industries, like school purchasing, for example. There are good food purchasing guidelines people are starting to work on. What we have to do is that as we change things where healthcare is funding around these non-medical social drivers, determinants, I use everything to please everyone here, of health, when we do that, we have to find a way to connect that work to that other base building work and say, well, when healthcare is paying, let's look at what kind of a thing it's paying for, and that we're not just like providing on the one hand and messing up on the other. So that would be kind of a strategic approach where for us, we start where the money is, because also we look at each of our individual sort of access to levers that we have. You have the AAMC, an academic medical system. You have direct access to patients. I have the ability to talk to healthcare insurance companies. That's something I do, and I don't know if I enjoy it, but I enjoy getting the most I can out of people that have money to pay for those that need it. And Matt, who we're going to turn to next for this sort of other angle to it, which is how do we really get the kind of data that we need? Matt has his big head, lots of great work around data. No, but used in other industries, large scale, and has now turned relatively recently to understanding the social drivers of health using some large national data sets. And so perhaps you can share a little bit about that approach to solving the problem.
Yeah, thanks for bringing it back for me, because I was going to say, could you repeat the question?
Whatever you want.
I'm also feeling a little imposter syndrome here, sitting with these three, because versus 25 years, I have more like 25 minutes of experience, and most of that's part of this panel. But I am participating as a scientist, not as a practitioner or a clinician or a policymaker. And so as Minnie has already indicated, and Craig's early slide has already shown, some of our work is looking at a large data set where we're focusing on trying to get a better understanding of how to measure social determinants of health so that they can be incorporated more effectively into clinical and policy decision making. The major data asset that Minnie has mentioned is the data set that we've been working with for the last year. It's a product by the CDC, CDC, All of Us. It has about 500,000 participants in it. It's entitled All of Us because it's supposed to represent all of us. It's a work in progress in terms of accruing a sample of up to 1 million participants. And just yesterday, they released about 300,000 more, a new tranche of respondents. I tried to get in and run some models last night, but didn't successfully do that. But the perspective I'm going to offer is more about how we can think about measuring social determinants so that it supports decision making. And I'm really happy to be able to talk to my fellow panelists as well as everyone in the room who has some actual hands-on experience in the trench experience working with social determinants, because what I think we understand is that for decades of work now is that social determinants do matter. They are the drivers, the non-medical drivers, as has been described here this morning. But which of them matter when and where? I think those are the kinds of questions that we're trying to address in our research. Which indications, which health outcomes are connected to which determinants or drivers? How are those moderated or mediated by other social position factors, demographic factors, or other patient-specific information? So that's the nature of our research, and part of what our quandary is, and where we'd like to have conversation, is how do we develop schema? How do we adopt a schema? There are several that are already out there. Some have 5 pillars, some have 10 pillars, some have 12 pillars. How do we recognize that these pillars are absolutely interacting and in a sense comorbid, that many of these things move together, and so separating out the effects and understanding the ability to personalize care with models that are using social determinant factors is challenging from that perspective, because they do all tend to point in the same direction at the same time. Those are some of the questions that we're trying to address in our research. And I feel like I just need to pass the baton back to continue the conversation, but I'm happy to talk more about the research that we're doing and the goals that we have as we go through the discussion.
Sure.
So
We'll have a few comments,
Okay.
and then we're going to go to questions. So
Okay.
questions or peeves, still, for those who have the peeves, are ready to share them and feel like they were cheated.
So I just wanted to voice my support for data.
That's right.
So in the clinical context, in terms of working with individual patients, what we do a lot is use population level data to understand who we need to reach out to. So we have regular care team meetings that are interdisciplinary. So we have behavioral health, nutritionist, our housing team, our case managers, and the clinician all meet once a month, and we look at data that we've collected from all of our patients about viral loads if there's somebody living with HIV, or if they've been out of care for 4 months or more, or if their eligibility has expired, and we know that their services are going to expire as a result of that. And we're able to kind of like target and outreach, and we have a conversation with the care team about, more of the qualitative what's going on in this patient's life. Why do we think they're unsuppressed in terms of their viral load? What are all of the nuanced, reasons why that might be? And then again, what is our tailored care plan to match those needs? So that's one way that data is super useful. The other way is looking at trends in terms of those social determinants of health and saying, okay, in general, if somebody comes with these certain characteristics, we know they're going to be at risk for XYZ medical issue in the future. And so there's the downside of that is, creating bias. And so being aware of not falling into that trap. But I found it very helpful to say, okay, if you've got these certain risk factors or these, social drivers, I need to be aware of the impact it's going to have on your health in this way. And so I'm going to be more proactive about, creating some ways in which I care for you in a medical context, just like we do for cardiovascular health. If I know that you smoke, if I know that you have a family history, I'm going to be more aggressive about your medical care in terms of protecting your heart. The same thing needs to happen for social drivers. If you have a history of migration, if you've migrated here, if you are a woman, I'm going to be looking for signs of trauma. I'm going to be asking about sexual abuse. I'm going to be more thoughtful about how I do this pap smear. There's so many different ways that we can use these kinds of trends and data to think about how we care for individual patients.
Great. Go ahead.
Corresponding
more data.
comment,
Love
I think
it. Yeah.
that part of our research, although we mentioned the big data set, that's very important. That's more of a tabular data. We have done interviews and talked with practitioners to get an understanding of the value of the narrative forms, the notes that clinicians prepare, and trying to understand how, for example, community health workers will administer a social determinants of health screener, but also follow up with probing questions to get an understanding of the context behind the more structured questions that are in the screeners. And so there's a variety of other large language model technologies that can be brought to bear to try and extract themes and understanding to improve prediction. One of the things that we're trying to do is as I said before, support decision making. And so we're interested in working with practitioners, policymakers to understand the information that they need to try to help improve decisions. And we definitely understand that just asking people 10 questions in a social determinant screener doesn't give you all the information you need.
Well, let me be controversial here and say, do we need screening in healthcare institutions? And I'm going to ask Chiquita to respond. Is that really the best place to do it, or is it just where we start? Because I love my physician colleagues. They're worried about this, and what they know is the clinical institution. So in fact, if you look at the work that's most happened in academic medicine, paper after paper after paper, it's about screening. What do you screen? How do you screen? And the screening is happening in hospitals and clinics. So the question is that just happening there? It's sort of like the light is, like the guy that was looking for the key, and he looks under the light.
That's
and then
a great
the cop
analogy.
comes around and says, like, why are you looking, what are you looking for the key? They look, and then he goes, like, where did you lose it? Oh, over there. But it's dark. So I hear there's light, right? And so I see there's some kind of a parallel here. So Chiquita, what do you think? Should we be screening only in the clinics, at all in the clinics, by physicians, or somewhere else?
So let me say there's added value in terms of getting information about the lived experience of a patient. It provides context and understanding their health situation. And so there is a lot of interest in terms of even having a more robust way in which we do that in terms of our electronic health records, which most health systems are now using. And so again, it gives us information, data to inform how we diagnose. And so that's all key, that's all important.
Wow, she let that one drop. I think there should be a lot more screening in a lot of other settings. Let me just put that out there and have, and then maybe.
I didn't say, that should be the only.
Gotcha.
But more or less, you need a multifaceted approach, right? So you can't just say this one is the, golden standard. You have to be inclusive, you have to be holistic in all those multifaceted approaches, okay?
I pretty much thought so. All right,
Just
Matt.
towards that very goal, one of our research aims is to look at how to collect information within the lived experience, across time, at the location of the experience that they're having. And so we are working towards technology that allows that to be removed from the office. It's not removed completely. Those screening tools can be used in the office, but we have a way to try to distribute that across the person's lived experience so that the data are being recorded more or less at the time that they're in that environment.
That's terrific. And other sources of data are like school data, which is notoriously hard to connect back to a health record. And there are a lot of challenges with that. But there are a lot of other places where sort of more granular data of life are being collected. Let's open it up for questions or continue on the peeves piece. That's fine from our audience. Yes.
It's off right now. You can turn it on.
Oh, we have one. She has one back there. I was wrong.
That's okay, I can talk really loud.
You can, yeah.
I was gonna say, so I'm not from a health background and not working in the health space, but working with health. So I'm working in the multifamily space and providing free telehealth services to working families. And social determinants of health is my favorite 3 words. Because outside of the context of a health setting, I think it's really hard for people to understand, as so many research has come out, that your health, financial, and educational outcomes determine most of your life. And so creating and understanding that this whole idea of community health hubs, and to bring it into a strategy point, my peeve is, why is all the data only ever funded and extracted from medical records and health centers? For example, community workers, like we just heard from Uvalde teams and how they're out there, and we just said the most important thing is trust and relationships. And people get paid for their data all the time. No, excuse me, white people get paid to give their data all the time. But our diverse and minority communities are forced to give over data and screenings at every single checkpoint. And that in itself is a barrier to access. And so what if we created and funded strategy systems that pulled on organic data from community health hubs and workers who are already there? I do a survey twice a year with my residents. I survey a lot of different times, but twice a year just on mental health. How many days this year did you feel great? How many days not great? What does mental health mean to you? Wouldn't that be great for their primary care provider to have? And they did it because they trust me and they know me. And so that's my, to tie into our communities of what is the next, but that's my peeve and love of social determinants of health.
Yes, ma'am, over here, there are 2. Yeah, thanks.
Hi, my name is Jen Hall, and I work at Austin Public Health. I just want to say that sometimes when people say Austin Public Health, they think high up. I am like a worker bee, okay? So I just be like, who is she? You won't Google me. So what I wanted to talk about is I work a lot with faith communities and community groups, supporting them, talking about social determinants of health. My pet peeve with social determinants of health is it doesn't mean anything to the community. They're like, what's determinants? Like all these big words. I don't get it. When we break it down, I believe that when I explain it, they get it. They understand. They're like, yeah, all these things affect my life. I get it. Okay. And those are the words? Sure, whatever. My problem is that We talked a little bit about resources and connecting people when we go into the communities. I do a lot of program design, and I work with a lot of community health workers, and my frustration is that they go and they find out the problem, they have these organic conversations, they listen, and then the resources are not there. They're hungry, and we can't get them the food. They need a provider, we can't get them the provider. And so I find that a lot of times we're not talking together. We're in these spaces, but I wish that there was less silos where I really had a connection. I really had a connection with all these things to get the things that we need and the funding and the money to get more mental health resources and get more providers and get the people in the schools. Like, I want all that. And I get frustrated being boots on the ground sometimes because people are telling me they want stuff, and you literally can't get it to them. And so I think that we ask plenty of questions. I think people are tired of answering every survey. We survey them in the community, we serve everywhere. But then the survey just sits. So I'm asking the panel, how do we address this problem that we all know? Like, how do we really make a difference and get our funding and the powers that be to actually make the difference and put mental health providers in the school, move that money around, put the things where we know it needs to be? So that's my question.
So I will address that. Thank you for that. I concur. We do function from a silo mentality. Sometimes we come from privileged environments and we feel that we know it all, right? And so if we don't begin building and forging partnerships with all sectors that can contribute to the betterment of a given population, that includes private industry, nonprofits, government, academia, then we're still going to be talking about this 10 years from now. And we have to include those who we are trying to meet their needs. They have to be at the table, not the result in terms of helicopter research. We want your data, and then we leave out because we got funding from NIH to do the work. But we have to come from an action-oriented, solution-oriented mentality, because it's not just in terms of me getting tenure at my ivory tower, but we have to be attentive and conscientious of how do we dismantle, remedy, mitigate in ways in which it's effective so people feel that we are providing a service that benefit them. So I think there are many examples that exist out there. I don't want to say that none of that exists. We have the Robert Wood Foundation, we have the Ford Foundation, and we have many others. We have local entities that are invested in those things. But to be more impactful, I think we have to come with the political will to do it and to invest in those communities. Because what we find here, even in Austin and most major cities, people are being displaced. They are in prime real estate areas that now we're investing in, right? When I used to be in the classroom, I used to tell my students, if there is a Starbucks and an ATM or banking institution, that's the neighborhood I want to live in. Because those are social amenities to conditions by which the quality of life, right? And studies have shown, countless studies have shown, that we live in qualitative different communities. We can talk the talk, but do we invest and do we actually have conversations with the folks that live in our community? So we have to get real. I mean, I think, there's so much studies that are out there to document this, and now we have to do the work.
Oh, sorry. I just really appreciate your comment, and that is, I think, one of the most important issues we see is that we do a lot of screening and intake of information, and then what do you actually do with it? So I think one of the most profound things that I have seen in primary care is we're taught in medicine to triage. If somebody is, the sicker they are, the more immediate you give them care and the more care that they're going to receive. We do not do that at all in healthcare. In fact, it's flipped, right? The funding for healthcare is totally flipped on its head for that. Patients who have the least resources, who face the most, discrimination, poverty, all the social determinants of health we've been talking about, end up having the least medical resources. So they're often in Texas uninsured. They have, underfunded clinic systems, less resources available. So I think that's the key, to talk to whoever the powers that be, in our, the leadership of our FQHCs, the leadership of our, central health, like everybody who's, at the table in terms of kind of structuring our policymakers, understanding that there need to be more resources put into those patients who have less, because that is the medical model. That is triage. And I've said it again, I think we all, I'm sure you as well as me, experience moral injury when we have these situations. And it leads, we talk about primary care burnout. This is a major driver of primary care burnout. Physicians and social workers and everybody in this field who really feel for their patients, it's miserable to know that they need something and you cannot give it to them. And so I think what we need to do is really advocate for, those most in need. We need nurse case managers for them. We need community health workers. We need housing teams in the clinic. We need all of that. And it is not full medical care. It is not appropriate care if we don't have that. And I think when we're talking about these grants that fund, say, at my clinic, we're a Ryan White clinic, so I can only provide these full panel of services that I described, housing, food pantry, all this great stuff, only if you're living with HIV. I also do HIV prevention, PrEP, for people who are not living with HIV. And I cannot give them full primary care. I have to walk them past my food pantry, and they say, I'm hungry, can I have some food? And we have to say, no, you don't have an HIV diagnosis. Like, that's crazy. And so the way that we are siloed, in terms of how we work, the healthcare system is siloed in terms of who we serve and who gets what services. And that has to fundamentally change. And there has to be, cooperation across different silos. We all got to, advocate for each other, not just for this disease state. I'll say one last thing that just kind of illustrates this point. For patient assistance programs, we're very duct taped in healthcare. We try to find this pocket of money, that resource, as a social worker, right? And I remember just talking to one of my patients recently, and I said, okay, so there's this website you can go to, and it's patient assistance by disease state. And you can see, there's different foundations that are focused on different diseases. So let's see if, you have rheumatoid arthritis and you need this expensive medication. Let's see if there's a foundation that funds that, because maybe you'll get lucky. That's our current state, and it's crazy.
Let me just add that the IC² Institute is in service of this very goal. As a think and do tank, we're about thinking and coming up with solutions, but also translating those into do programs that can address that. And in regard to some of the work that I've been describing here, I mentioned decision support models for clinicians, but also policymakers. That function is more about resource allocation and prioritizing where we spend money and make investments. And so part of our work is directed exactly at that. It's a long way to go. It's a wicked, enduring problem, but that's part of what we're trying to do as a think and do tank.
Thank you. Matt, I swear. Oh. Can you hear me? Matt, I swear we didn't coordinate this, but my question was actually going to be, can you guys speak a little bit to what it's like to advocate for various communities, given some of the really anti-data, even anti-science trends, anti-facts, post-factual universe that we live in from a policy-making standpoint? And I guess if that's not a comfortable question to answer, then I would ask, what would you say to policymakers about the deeply human cost of that approach to making policies that affect the health, life, and death of citizens?
I think we all welcome uncomfortable questions, but probably other panelists can address this better than I can right now.
Let me try one stab at that. So, it's not an uncomfortable question at all. I think it's what we all wrestle with. It's fine, this is the work. But one approach we've taken, and so I do think, how, when we do research, which is one part of what, for example, I do, but I do it in the service of what decisions do I want to sway. And you can get really targeted. And actually, the more targeted you get, the less well you do in academia. I can tell you. That doesn't get you promoted necessarily, but it might get you to a policy change. And so, for example, we did a program where we supported caregivers, primarily parents, for children. And we looked to see if when parents were supported would they be able to help their children improve their diet rather than prescribing something very prescriptive? And we got a striking answer, which was yes. I mean, of course, you'll all go, well, duh, but it doesn't happen often enough. But we were going to do it in the traditional way, if you look at the literature, which was to give a produce voucher, or something that said, this is healthy, so here's something that constrains you to the healthy. Luckily, that started getting hard to implement, and we have a good enough team that we were just like, stop, wait. Why are we doing this? What is the income status of the people that we're supporting? And the income status, by the way, 70% or below federal poverty level, which means even everyone else was terribly off given where federal poverty level sits today, and this was in Austin. And so we ended up giving grocery store cards. Now what that did, and this is now for the future as well, we got results. We got really good results, but we got results on healthier eating for their children, even though we did not constrain them to only buy healthy. We let them choose, because the answer there, and this is a little bitty approach to starting to open the aperture, and rather than say, thou shalt, and of course, if we just let you go, you wouldn't do it that way, so we will constrain, like WIC, for example. Don't get me pet peeves. Don't get me started on WIC, and you can have cheddar, but not shop cheddar, and what a demeaning sort of approach to supporting people. But I bring that up because then we worked with a Medicaid MCO in Rio Grande Valley to support moms, and we want them to start paying for food for moms, which we did get with the support of some, this is, by the way, work, I have some great foundation supporters in the room, which I don't want to particularly highlight, but we couldn't do this work without foundations really wanting to catalyze a change. The point is, they began by saying produce vouchers. They began by saying, let's do something where we can actually check. Oh, the team started saying, how do we know that they actually bought fruits and vegetables? That kind of language. We could go to them and say, hey, by the way, look what worked when we didn't even do that and we just used grocery store cards. Would you be interested in perhaps opening your viewpoint a little bit and letting them just have grocery store cards? Because they have so many needs. Who are we to say when one day they want to use the card for milk versus, or yogurt or whatever versus fruits and vegetables? And they agreed. And they agreed because the earlier results had shown that. Now, these are just some steps, and more has to happen. The other frame we're looking at is for research aligned with decision making. Looking at things like cash equivalents is super interesting, right? So if there's a very complicated social drivers program, but you can give basically the same cash to someone, and if you can get the same results, then why on earth would you do the complicated program? Let's just give cash. Now, this is cash in small amounts, but if you can start really demonstrating the value of cash in small amounts, it starts playing into the argument making for a range of things. Wait, so you're giving, why aren't their incomes higher? Why do we have to have health care to, So there are ways to start. Don't tell me I'm wrong about this because I'm working on this. So don't tell me we're going to fail. You have to choose the strategies you hold on to. But I do think that there are ways to take the expertise that's on this panel, for example, and really start thinking about what are the nodes I want to change, and how are the people in charge of that node? What info do they need, and what is it that we think we can push them to do? And then there's a chain of these. That is the way, at least, I approach, trying to bring, to your point, real resources. And it addresses the freedom, the pieces of freedom of choice, and why is someone less human just because they need some assistance, which drives me nuts.
Needs of trust in there, too.
Yeah, exactly, trust. Let's trust that a parent will want the best for their child. Let's start there, not somewhere else.
I would say, just from to your question about how to talk in this anti-science climate from an advocacy standpoint. So I do gender affirming care for adults and have been advocating, and that's probably the most anti-science or one of the most anti-science things we're fighting right now. And I think coming from lessons I've learned both in terms of advocating for patients in the clinical setting to get more funding or time for physicians to care for them, and in that sort of more legislative context is it doesn't feel really good in the moment because it's not what you really want to say, but understanding what is actually going to resonate with this person who disagrees with me. So they have a different viewpoint. If I just state the facts, it's probably not going to get anywhere, unfortunately. And so finding some sort of common ground or some sort of issue that is related and palatable that might get them on board. For instance, when we're talking with, our clinical partners and trying to get longer visit times for our more complicated patients, talking about how, we both come from the same perspective where we want our patients to be healthy and we want the clinic to be successful, and coming from that mutual understanding. And I want to hear from you how you think that's going to work, so you understand their perspective, and then repeating that, and then like bridging to your point. I hear that you think that this is the challenge that you have. I wonder if we could blah, blah, blah. Because I've definitely done the guns blazing, hey, listen to me, this is my idea, this is what's going to work, and people just shut down. From the legislative facts part, unfortunately, we know in some situations, me telling you every major medical organization supports thoughtful, evidence-based gender-affirming care, that's just not going to fly with a lot of our legislators, for example. And so let's talk about patient autonomy and the patient-provider relationship and the sanctity of that relationship. And, so there's different ways to attack the problem based on what the person you're speaking to will actually hear. Yeah.
We have to wrap up, but I'm going to ask Chiquita if you can just close us off with a very brief, let's call it something that's going to inspire people to go put up thoughts on Think, Do, Fund.
Lovely. What a charge. I remain optimistic.
Thank goodness.
I've been in this business for a long time, and listen, being a mother of two African American boys growing up in America, I have to know that I'm going to do my part as others have done for me, and we have to come from a collective lens and not assume that one entity is going to be the solution to all of our social problems in our society today. And there are many prime examples that we didn't have opportunity to share, and so we don't have to reinvent the wheel. We can replicate those that are best practices or successes that are applicable to our needs here. And given that all of you are in this room today, we know that we have a lot ahead of us as it pertains to, but we have to make sure that we work together, those who can see, solutions to the problems that we address today. And I'll leave you with that.
Awesome. Thank you.